Good afternoon. My name is Josh Glenn, and I'm a pediatric surgeon practicing in Central Georgia. The topic of my presentation is biliary disease in children. I have no relevant relationships to disclose. Biliary disease in children falls into two general categories, acquired and congenital. We will focus mainly on the acquired disease, including cholelithiasis, choledocholithiasis, and gallbladder polyps. Occasionally, the general surgeon will be asked to see a patient with hydrops or acalculous cholecystitis after resuscitation from sepsis or shock, but increasingly these patients are cared for at pediatric centers and are less likely to be encountered in a general surgery practice. Their management is the same as in adults. Of the congenital anomalies, aberrant ductal anatomy are the most common, however, are still relatively rare. Choledocholithiasis may present later in adolescence and adulthood. Biliary atresia presents in infancy and is rarely encountered by non-pediatric surgeons. Cholelithiasis is common in adults and relatively uncommon in children. However, the incidence has increased over the past couple decades. The epidemic of childhood obesity has certainly contributed, as well as the ready availability of ultrasound. The percent of pediatric gallstone disease due to hemolytic disorders has decreased relatively, mainly due to the increased incidence of cholesterol stones. Still, hemoglobinopathies account for 20 to 40% of pediatric gallstone disease. The distribution of gallstones differs in adults and children. The majority of stones in the adult population are cholesterol. Black pigment stones from the supersaturation of bile with calcium bilirubinate make up the majority of pediatric cholelithiasis. These are commonly seen with hemolytic disorders and long-term parenteral nutrition. The presentation of symptomatic cholelithiasis is similar in adults and children. It is more difficult if the child is not old enough to communicate their symptoms. Cholelithiasis should also be considered in patients with nonspecific intermittent abdominal pain, especially with risk factors such as chronic hemolysis, obesity, or family history of gallstones. Asymptomatically found gallstones make up 30 to 40% of cholelithiasis in children. The evaluation is similar to adults. Routine lab work, including liver function studies, complete blood count, and amylase and lipase as suspected pancreatitis. Abdominal x-rays are usually not helpful unless ruling out lower lobar pneumonia. Ultrasound is the imaging modality of choice and is highly sensitive and specific as in adults. HIDA is useful to evaluate for chronic cholecystitis or dyskinesia. CT scans of the abdomen are rarely helpful unless a diagnosis is unsure, or to evaluate the pancreas in cases of acute pancreatitis. MRCP is very good for ductal anatomy and to evaluate choledocholithiasis. It avoids radiation, however, often needs sedation, especially in younger children. For symptomatic patients, laparoscopic cholecystectomy is standard of care. Traditional multi-port or single-site laparoscopic cholecystectomy have been demonstrated safe and effective in children with low postoperative complications, including patients with hemoglobinopathies. Open cholecystectomy is reserved for patients in whom laparoscopy is contraindicated, such as a patient with severe cardiopulmonary compromise. Observation is safe in healthy asymptomatic patients. Cholecystectomy is recommended in asymptomatic patients with sickle cell disease and gallstones due to the high morbidity and mortality rates associated with emergency cholecystectomy and cholecystitis. These patients need preoperative optimization and coordination with their hematologist. Patients with hereditary spherocytosis and asymptomatic gallstones may benefit from a combined cholecystectomy and splenectomy. However, if no stones are present, cholecystectomy is usually unnecessary as the risk of developing biliary disease after splenectomy is low. Clinical jaundice, elevated bilirubin, pancreatitis, or enlargement of the common bile duct on ultrasound or indications of potential choledocholithiasis as in adult patients. MRCP is a useful screening test to confirm the presence of choledocholithiasis and possibly prevent some more invasive ERCP. Preoperative clearance of the common bile duct by ERCP is a well-established treatment prior to cholecystectomy. The difficulty in children is obtaining this intervention, as not all facilities will have gastroenterologists who are comfortable performing this in smaller children or have the equipment necessary. The other potential drawback of preoperative ERCP is the need for multiple procedures, increased length of stay, and potential for post-ERCP pancreatitis. Some centers advocate cholecystectomy with intraoperative cholangiogram and postoperative ERCP for ductal clearance or laparoscopic common bile duct exploration. Laparoscopic cholecystectomy with intraoperative cholangiogram has the potential to require less interventions. A recent study performed at the University of Michigan demonstrated only a third of patients who had suspected choledocholithiasis and underwent primary cholecystectomy had a positive intraoperative cholangiogram that necessitated further intervention. The use of laparoscopic common bile duct exploration has declined due to lack of training and the more widespread availability of ERCP. Adoption of this technique requires access to necessary tools such as catheters, balloon dilators, and choledocoscopes, as well as the skill set and knowledge of all the staff in their use. In my practice, I currently perform primary cholecystectomy with intraoperative cholangiogram and suspected choledocholithiasis with either laparoscopic transcystic common bile duct exploration or postoperative ERCP ductal clearance. Gallbladder polyps are rare in the pediatric population, however, are more frequently identified. Rarely do they present as a malignant process. Asymptomatic patients can safely be observed with routine ultrasonography for polyps less than 1 centimeter. Recommendation for cholecystectomy includes polyps greater than or equal to 1 centimeter and symptomatic patients. In summary, choledocholithiasis is relatively uncommon in the pediatric population. However, its incidence is increasing with the increase of obesity and cholesterol stones. Observation of asymptomatic choledocholithiasis is advocated unless the patient has sickle cell disease. Choledocholithiasis can present a challenge in the pediatric population due to lack of ERCP availability at all institutions and/or familiarity with laparoscopic common bile duct exploration. Consider early referral to a center with ERCP capabilities. Thank you.